Hi, welcome to the Avaz Health Podcast. We're going to be talking today about a topic we've touched on before, menopause. Why? Because it's been in the media quite a bit. People are talking about it wherever they're gathering, and there's been some information that we think is really important for you to know, more details on what we touched on in our first season. I'm Roop, your moderator, with Dr. Nav and Dr. Madhu. So let's get into it. Menopause. It's a very important topic. In particular, as South Asians, we don't talk about it. And I got to say that when my mom was going through menopause, I had no idea. No idea. So, all of a sudden it feels like it's something new and people are suddenly talking about it. But what is it that we really need to know about menopause as it affects women in the Middle Ages?
Yeah, I think that's a fantastic question because we are hearing more about it nowadays because we're not considering it a taboo subject anymore. And certainly from my perspective as a woman in midlife and as a physician, I discuss this with my friends and my colleagues and patients all the time. And so I think it's a really relevant topic, even though we brought it up before. So I actually recently attended a conference on menopause and perimenopause, and I really am excited to share all the information I learned. In fact, we had so much information we had to really kind of parse it down for this episode, but I think our listeners will get a really good idea of what to expect during the perimenopause time.
Yeah, I mean, the purpose of this podcast is to really discuss it openly because I think as you said, I didn't know my mom even went through menopause. Because according to her, it's normal. Tika, kuch nahi hai I mean, mari janne. So I don't agree with that. Menopause is a real thing. We're here to open up the discussion so you can have healthy talks with your physician, with your friends, and take it from there.
Okay, so we know you have a lot of questions. I had a lot of questions for our doctors, and so we're going to go through some of those, and let's dive in.
Yeah.
First question, there's perimenopause and there's menopause. Let's start with the definitions. What is perimenopause?
Sure. Before we start with perimenopause, let's talk about what menopause is. Menopause is actually a standard definition, which means that you've gone 12 months without having a period. So that's it. That's all menopause is. But perimenopause is the time leading up to that. So that could be anywhere up to 10 to 12 years before you hit menopause. And that's a time when your hormones are just fluctuating wildly like a roller coaster. You kind of have to think of it like puberty in reverse, actually.
Yeah, and the sad part is that when women are going through perimenopause, their kids are probably going through puberty.
That's
So
right,
it's
yeah.
really creates havoc in the house. But perimenopause, like you said, starts 10 to 12 years before menopause, and your hormones are totally in fluctuation. And one thing that you had taken from your conference, which I did like, is it's predictably unpredictable. So anything goes. Your periods could come heavy, they could come light, you could skip a couple of months, you could get them every 2 weeks. So there's no sort of right or wrong. Can get mood swings, anxiety, insomnia, migraines, estrogen drops in windows. So as Dr. Nav already said, the hormones are just going all over the place. And then we start getting symptoms in addition to all of the ones I've described. Hot flashes can occur, and we associate them with menopause, but you can still have your periods and get hot flashes, hair loss, the low libido, but there's other things that contribute to that as well. Libido meaning sex drive, and the terrible weight gain, which is an actual factual part of menopause.
And how about irritability?
Yeah.
Wait, who's irritable during menopause?
So it sounds like a lot of really uncomfortable things to deal with, not just for yourself, but the people that you're probably living with as well, right? Because if we didn't understand it until we're sort of hitting this middle age, then our partners and our children may not know what's going on with us either.
Well, they're not going through it, so it's hard for them to understand
Or to
unless we talk about it.
Yeah.
Exactly.
And, along with what Dr. Mother said, like that's sort of the beginning of the perimenopause phase, and it gets even worse as you get closer to the menopause time.
Yeah.
So when you hit your sort of mid 40s, anywhere up until the late 50s, that's when your hormone levels really drop, and then your periods start to like disappear for months at a time. You're like, am I not in menopause? That's when all of your symptoms that Dr. Mother described get even worse. And then that's when also your urinary symptoms start. And we'll talk a little bit more about that later.
Okay. So it affects you for those whatever 10 to 15 years that you're in perimenopause, but there's also long-term effects, correct?
Absolutely. So a huge impact. Our LDL, which is one of the bad cholesterols, that does tend to start rising in the perimenopausal ages. And once you're in menopause, it does increase as well. So it's not just genetics or what you're eating, it is an actual metabolic change linked to menopause. Bone loss. So our bones aren't as dense. So we call that osteopenia or osteoporosis. We've already done a podcast on that. So please listen to that if you need to know more information. Bone loss starts when you're in our 30s, but once you hit menopause, because the estrogen's dropping, it really does have a bigger impact in terms of how dense and strong our bones are. We lose muscle mass, so lean muscle, and of course we gain fat mass. It's horrible, horrible. So you do gain weight despite diet and exercise. Again, a metabolic change. And I really don't want to say this, but it's true because my kids always, when I forget things, go, "Are you demented, Mom?" Like, you do have brain changes. The PET scans are showing that your brain activity can drop up to 30%.
Wow.
And it doesn't fully recover. So now when my son says, "Mom, you think you're getting demented?" I'm going to say, yes, yes, I am.
But that is an important point too, though, right? Because we don't know whether it's just temporary or whether we're going to be like going full permanently into the land of cognitive decline.
Or your life could
right?
be just driving you nuts.
Yeah, or yeah, just general life.
Just general life.
I mean, I love being a woman, but we get hit with puberty, childbirth,
Yes,
you know,
yes.
and now menopause.
Yes.
Like it seems like our hormones are all over the place. Maybe every couple of decades it switches.
Mhm.
But so this perimenopause is due to our hormones changing, right?
Yeah.
So what's happening?
Well, basically, it's a drop in estrogen and progesterone. Like those are our two predominant hormones in women, and they're not just responsible for menstrual cycles. They're also responsible for our energy balance, our sleep, our mood,
Our hair.
our hair, yeah, our hair, our muscle health, metabolism, everything. So that's why you see such a change in an overall health pattern once you start to hit the drops in those levels.
Okay.
Not fun.
So how do we know that this is happening? How do we know we're in perimenopause? How do we diagnose
With
it?
hormones, you really have to listen to your symptoms. So I think we've emphasized in previous podcasts is that our hormones really do change. It's not a constant thing that we can measure. If I measured it now and I measured it tomorrow, totally different levels, right? So they change. So first of all, history again. Look at the person's age, talk about their history, what's happening with their periods. Let's talk about that. So there's no real magic blood test for perimenopause. You really have to listen. Um, because your hormones are fluctuating, maybe you take it and that test might show, oh, she's in menopause. And this has happened with me when patients really insist I want it. And then I show them, I go, look, we did it here. It showed you're in menopause. Now we did it. Now, a few months later, you're not in menopause. So this is perimenopause where it's fluctuating. So we've proven what we're talking about. So the blood work's not that crucial. What is crucial is getting your pap test done. If you need your bone density, getting your bone density done, making sure your metabolic health, meaning you're good for your cholesterol checkups, your diabetes checkup, your mental health, good mental support, exercise, nutrition. So back to the basics for almost every disease process is really looking at those things first.
Okay. So we've talked about the symptoms and sort of like when it sort of hits you. And if you're going to go through it for like 10 to 15 years, that's a long time to be going through all of those symptoms. I understand like from like not even very long ago, but hormone therapy, which we used to know as HRT and is now called
Menopausal hormone therapy.
menopausal hormone therapy. It wasn't recommended because there was a study that said it was harmful, but that has now been refuted. What can you tell us about the study?
Multiple times, but you actually brought up a good point about it used to be called HRT and now we're referring to it as MHT, and that's because we don't like the word replacement, right? Hormone replacement implies that you're deficient. And why should women, because all women are going to go through menopause,
quite a large.
why should we be considered as having a deficiency?
Yeah.
I mean, if you're giving testosterone replacement to men, you're not calling it
my
hormone
God,
replacement
I
therapy
didn't
for men,
think
right?
about that. That's empowering.
Yeah, totally.
And it's not empowering for women.
Exactly.
Oh,
Exactly.
God.
Hence the
Thank
transition
you.
to the new terminology. So
Menopause replacement therapy.
menopause, no, not
menopause.
Because we don't need replacement.
We don't need replacement.
We don't need replacement for anything, ladies.
Okay.
So yeah, so this study that you mentioned, the WHI or the Women's Health Initiative from 2002, and we have discussed this the last time we talked about menopause, but I'll just bring it up again because I think it's important to know
Yeah, it is.
why we got to where we got to today in terms of hormones. So that study was actually meant to be a prevention study. It was meant to look at the role of hormone therapy in preventing heart disease, bone loss, fractures, breast cancer in women who had already gone through menopause. So in fact, the study participants on average were 63 years of age, which is well past the time of
Yeah, you
menopause,
shouldn't be. Yeah.
right?
Yeah.
So that study wasn't actually meant to check to see whether hormone therapy helped with women's symptoms at the time of menopause. Okay, it was meant to see did it prevent these things well after menopause was done and over with. And what it found was that when they looked at these women, they did find that there was an increase in the relative risk of women who developed heart disease, like heart attacks and strokes. There was a relative increased risk in women who developed breast cancer. But surprisingly, well, sorry, not surprisingly, but also they found that there was a lower risk of colorectal cancer and a lower risk of bone fractures. But because they found that these women were having a higher relative incidence of heart attacks and strokes and breast cancer, they stopped the study and they did not study it anymore. And that was in 2002, and that's what hit the media.
Yeah.
But the issue was we've talked about relative risk versus absolute risk before. And I'll just kind of, for the listeners, I'll just throw out a few numbers to give you an idea. So let's say your risk of getting breast cancer without taking the hormones was like 1 in 100,000 women.
Okay.
And then if you took the hormones, that risk increased to, say, 5 out of 100,000 women.
Okay.
So just imagine the media headlines. 5 times increase in the number of women that were getting breast cancer, even though the actual absolute number of women that were now getting higher risk of heart disease and stroke and breast cancer was still very, very low. But because of the way it hit the headlines, people are like, put the brakes on this. We're not going to be prescribing hormone therapy anymore. So from 2002 for another almost 2 decades, it was like, no, no, no to any sort of hormone therapy. And they specifically use hormones in that we don't use today. So those were not tolerated as well. There were some, indication that they did have a higher risk. Plus, the important thing is that they were started well
Yes, I
after
think that's the
menopause.
important
Yeah.
part, because then you've also missed the time where you reduce your risks for heart attacks and
Higher
strokes.
benefit.
And since then, they've used the current hormones and they've used it on women who are in perimenopause. So they're actually seeing the results on the women who have those symptoms
In real time.
Yeah.
Correct.
So what's happened is the impacts are huge, because when this came out, there's a huge distrust. And of course, as medical bodies, then you have to listen to these studies, you have to listen to the public, and you go, okay, there's warnings. The prescriptions went down. People were in an era of distrust of hormones, thought they were bad for them. And there was, love this term, hormonophobia.
Yeah.
And millions of women, unfortunately, were left untreated. And that honestly probably led to a lot more problems.
Wow. So a whole generation of women before us have been suffering perimenopause symptoms without any relief.
Yeah.
Okay. So you said things have changed. What do we know differently about menopause hormone therapy?
Yeah.
MHT.
MHT, yeah. So exactly what we were saying, the timing matters, right? So if you want to reduce the risks and you want to improve the benefits, it's best to start menopausal hormone therapy within 10 years of your last period or by the age of 60. So
And if you have symptoms.
If you have symptoms, yes, if you have symptoms, exactly.
Okay.
Yeah.
Okay. So let's talk about menopause hormone therapy.
Sorry, can I add one more thing? So I was going to say, with respect to heart disease as well. So menopause hormone therapy doesn't cause cardiovascular disease. Let's just be very
No, it
clear
does
about
not.
that.
Yeah, it does not.
You may already have a predisposition because of other risk factors. And again, in South Asian women, we of course have a higher predisposition, but menopause therapy may cause it to come out, but it's not going to create it.
Okay. So you're not going to get higher risk of cancer or higher risk of heart disease by being on hormones.
If you don't have a pre-existing predilection to either. Yeah.
Okay. And so this hormone therapy is mostly estrogen?
Well, it's both. It's estrogen and progesterone.
Okay.
The only time you wouldn't use progesterone is if your uterus is out.
Okay.
Yeah, but because you have to balance it. You don't want an overgrowth of the lining of your uterus.
Okay.
Yeah.
And so what forms does it take? How do you take it? What is it?
So estrogen is taken in two forms. You can have a systemic form or a topical form. So systemic is a pill or a gel usually, it's going into your bloodstream. So I have patients who come and they'll get patches or they'll take a pill. So those are the big things that I've used.
Is that like a birth control pill? You take it every day, or?
I take it every day, yeah.
And the patch is like a Band-Aid with some.
It's just a patch that you put on usually it's on your abdomen, I think. I think it
Yeah.
can be on your arm, but I think it's usually abdomen.
And I use a gel, so that it's also available in gel form, which you basically just use like a lotion all over your body.
Do you use it all over your body or do you use it in your inner thigh?
So that's what they
Yeah.
said initially.
Okay,
But
so
you can use it anywhere in your body as long as
Okay.
it's not on your breasts. That's what they
Okay,
said. Yeah.
I did not know that.
And so
that is
you would
good to
use that
know.
every day as well, this gel?
Mhm. Yeah.
Yeah.
And you can titrate it up or down. You could take 1 pump or
Or
2,
two pumps,
depending
yeah.
on how much symptoms
Yeah.
you're having.
Yeah.
And that slowly goes into your body, gets absorbed by your body, and it's the estrogen that your body needs to get rid of some of those symptoms. Okay, I get it.
Yeah, so transdermal or like the patches or the gel delivers the estrogen directly into your bloodstream. So it bypasses your liver. So it is safer for those who are at risk for blood clots, stroke, or who have certain liver issues. The pills go through our digestive system and do get processed by the liver. So that's important to know. And it can potentially also improve your HDL, which I did not know.
If you take the oral
If
form
the,
of
or take the
estrogen,
oral
yeah.
form, but it can increase your clotting risk. So these are all very relatively low risks, like 0.001% or something. So now the topical estrogen, we talked about the gel form, but there's a local form that you can apply. So this doesn't affect your whole body, but some women, a lot of women in my practice are older and they'll have dryness or something in their vaginal area. So you can put Premarin or estrogen vaginal cream in that area a few times a week, and that helps with dryness or any irritation in the
So there's
vaginal
so
area.
many forms of hormone therapy that people can, or women can take. And so how long would you actually use this for?
Again, it has to be individualized because of the study that came and we sort of lost data and it wasn't studied properly, right? So, but you can take it forever, but it should be reevaluated every year just to see how you're doing. So I do have women in my practice who one had a hysterectomy and she's on the estrogen pill and she's close to 60. I have another woman who's on estrase and she's had a hysterectomy as well, so she doesn't need the progesterone. And she's like 75 and she's still on it. If she goes off it, she doesn't feel well. And she's monitored every year for everything. We reevaluate it and it's fine. So you have to look at what is their quality of life, what is their health history, their risks of cancer, coronary artery disease, blood clots. And then there's the super flashers, the ones who really get really bad hot flashes. And they may need to use it for a longer time, or women who have really bad, and we'll talk about this later on, genitourinary symptoms. So when you pee, basically, those kind of symptoms. But we'll come back to that shortly.
Okay, so, social media is a big source of, I was gonna say fake
Oh,
news,
not
but I
your
don't want to use that term. But we get a lot of misinformation
Yeah,
from
a lot of-
social
yeah,
media, right?
tons.
And I hear so much about, oh, this supplement and boost your hormones and buy this product. It feels like people are just trying to sell a product and say that this is going to resolve all of your problems. So one of the things that I've seen online is that people are asking for, I think it's bioidentical hormones, as if this is the latest and greatest thing. Like, should I be on it? What is it?
So it's such a gimmick. It's a marketing term. Bioidentical basically just means it's created in a lab, but it's created to basically be the same as what we produce in our bodies. So it is identical biologically to what we make. So it's produced in a lab, yes, but it's approved by FDA, Health Canada, wherever you are in the world, and it is essentially the same hormones that you would be producing naturally, but it's been created. So everything that's out there right now that's available, that's prescription, and that's prescribed by your healthcare provider, is actually bioidentical. You don't need to go out there looking for supplements online from fake peddlers. You just need to go to your family physician and get this prescription, or your OBGYN or your nurse practitioner, whoever prescribes you your hormone therapy, and ask for the usual, which is the estrogen, either transdermal or oral. And if you have a uterus, asking for the micronized progesterone. And these have been studied, and they show the highest tolerability, the lowest side effects, and the sort of lowest risk of producing
Mhm.
long-term bad side effects. So there's no problem taking them. Don't worry about the fact that you need to find something that's plant-based or vegetable
It's so
based, or
gimmicky.
or celebrities are using this or that. It's the same.
Yeah.
Okay. So go to your doctor and get it prescribed from your doctor.
Yeah, they're well, you wanna take stuff that's well studied,
Oh,
right?
yeah.
Yeah. Like, I've had some patients come in and they'll talk about, I've got this compounded estrogen, maybe it's from a naturopath or some other provider, but they're not safer. You don't know how they're absorbing, you don't know how they're compounded. Honestly, a good compounding pharmacy probably won't even make it. And good compounding pharmacies are gold. Like, they know how to make stuff, but you don't need to make this. It's
Mhm.
not well studied. We don't know how it's absorbed. Um, especially here in my notes here, I have to read this. Absorption's unpredictable, especially compounded micronized progesterone cream. It's not reliable for uterine protection then, and that's huge.
Yeah.
You
That's why we
need,
give progesterone pills.
yes,
Okay.
Yeah.
because the pills protect the lining of the uterus so that from cancer, and so that's really important. So, that's all I gotta say. Get the real stuff that's out
Mhm.
there that's well studied by and approved by Health Canada and at the FDA.
So this hormone therapy, will it eliminate all of those symptoms of perimenopause, or will it just reduce them?
It will mostly eliminate vasomotor symptoms for sure. It will reduce many of the other symptoms.
And vasomotor symptoms are increase in blood flow, right? Is that what it is?
Hot
So I
flashes,
get
night
hot
sweats.
flashes,
Mhm.
even like during the day, at night. I get night sweats, and I never used to have this. And so it's just, I feel like it's just started maybe 4 or 5 months ago, maybe even longer. I don't know. Um, and kicking the covers off, and then you just finally cool down, and you're cold, and
Yeah,
you
yeah,
bundle up again,
yeah. Do you
and
know
it
why that
wakes me
happens?
up.
You know why that happens?
No.
It's actually starts in the brain. So you have a temperature regular center of your brain that tells you when you're too hot, and it cools you off by making you sweat. So that's normal.
Mm.
What happens around perimenopause is that gets all freaky because of the hormones changing. And so your brain tells you you are hot and overheated, even though you're not. So your blood vessels dilate, your
Yeah.
face flushes, and then you start to sweat to cool your body down. So once you've had a few seconds to a couple of minutes of your body cooling down, then you're like, it switches off again. You're like, wait a second, now I'm cold. It's like a thermostat in a room.
Yeah.
Now I'm cold, and that's so you start to shiver.
It's a
And
broken
yeah,
thermostat.
it really is a broken thermostat. That's exactly how we describe it.
So when will I have some relief? When do these hot flashes end?
Oh, you're not gonna like this answer. So we know now that about 60 to 80% of women will experience vasomotor symptoms during perimenopause. And for some women, it might just be they have the occasional hot flash at night or during the day, but they kind of just, breeze through perimenopause without any issues. Whereas other women, like me, will have will have them multiple times during the night, during the day, to the point where it's affecting your sleep, it's affecting your mood, it's affecting everybody around you. And so that's 60 to 80% of women will have vasomotor symptoms.
Mhm.
Um, about 50% of women who go through menopause, which is everybody, will have them up to 7 years. So it could be as little as a year or two. It could be as long as 7 years. And then there's a very few unfortunate ones, 15% of women who will have it for over or up to 15
Which
years.
is what I told you, my older patients still have
Yeah.
to take the esterase.
Thank you. Thank you for that. I hope I'm one of the ones that doesn't have it for very long, because it is
It
an
really varies, like, even amongst us, it varies. Like, you were a
Mhm.
super flasher.
Yeah, yeah.
This just sounds wrong.
and,
Anyways.
but you took hormone therapy
Yeah.
to
so I-
relieve that.
Yeah, yeah.
I have not, because I'm not it's not prescribed to me because I've had breast cancer.
Yeah.
Are there other people that can't or shouldn't take estrogen or hormone therapy?
Well, I think it's so individual, so it's so hard for us to give a blanket statement. But mm, the hormones aren't magical. Menopause isn't a hormone deficiency; it's a transition state. It's a rite of passage, and it's okay. But if you are having symptoms, then you should get menopause hormone therapy, and that will be tailored to your specific symptoms, how bad they are, and your personal history.
Mhm.
So I get the occasional hot flash, so I don't need to take it. So it really is on symptoms. We are not, it is not, it does not prevent, we don't give it to prevent osteoporosis. No, that's a side benefit that your bones get stronger when you're on it. But to exercise, do stuff like that. So you still have to do all that stuff.
Yeah, I mean, bottom line is you don't need to be on hormone therapy in menopause, but if you do need to be on it, it's great.
Yeah.
So that's a
It's,
bottom
and it's safe. It's okay. But
Yeah.
talk to your doctor.
I like how you phrased it as it's a rite of passage.
It is a rite of passage. You should own it.
We should own it, but we
Yeah.
shouldn't be uncomfortable through it, right?
No, you shouldn't. But women's health has not been studied properly. South Asian health is a whole other gap, like not at all. So as South Asian women, let's advocate for ourselves. Let's advocate for women. Let's educate women. And just the other day, I had a patient come in and she was going through perimenopausal changes. I started therapy on her and I did the estrogel and the progesterone pill. So she came in a month later. She goes, "You've changed my life." She goes, "I am back to normal now." And it was, I go, "Wow." I go, "I'm doing a podcast and I'm going to talk about you," because it was like, thank you.
Well, sometimes you don't realize how bad your symptoms are, how much they're affecting you until you've had the treatment and you're like, "Oh my goodness, I was really unhappy or miserable or low energy or low mood." And then you get on whatever the therapy is or the medicine is and you're like, "I feel 100% better." So some of the other symptoms,
Yes, let's talk about those,
which
please.
thankfully I cannot relate to at this point,
Yeah.
are the genitourinary symptoms.
Yes.
Dryness,
Irritation.
irritation in your, I'm not a doctor, so I could say the down there regions. But you guys are doctors, so tell me what's happening.
Yeah.
Yeah, lots happening.
Lots happening down there. Yeah, I know. And this is why we do this podcast, so we can talk about all the stuff that you probably don't want to be talking about with other
So
people.
let's talk about the embarrassing stuff.
Yeah. Okay, let's do it.
Let's do it. Go.
Genitourinary syndrome of menopause, or GSM. So what is it? So it has to do with the effects of estrogen deficiency on all your down there bits, like you said. So whether that's your vulva, your vagina, your urethra, your bladder, all the down there bits that start to, yes, dry up, shrivel up.
I was
Yes.
You went from a grape to a raisin.
Exactly, as you go through menopause. And not all women will experience it, but there are a significant number of women for whom it is disturbing enough that they need some treatment for it.
Yeah.
So we'll talk a bit more about that.
And the symptoms are also pain during intercourse, and
That's
that you
right.
got to pee, and you might leak.
Yes.
So a lot of women will come to my office and I think, "I have a bladder infection, I'm leaking."
Yeah.
And then you have to sort of, as a physician, clue in, well, no, it's probably your age. Like you can do the urinalysis.
You mean leaking when doing a running or jumping exercise, or
no,
just leaking throughout the day?
It's just a little bit, you just have to go in urgency.
Yeah.
Yeah, it's like an urgency, not like
Your bladder's not full. But you
yeah,
feel like
not
you're
like
running stuff.
incontinence. That's another podcast we did, but it's just an urgency. So that's what it is, and if it's like, and also burning with urination because it's dry there, so it hurts to pee.
Yeah.
And that's also, it gets confused with a bladder infection very often.
Yeah.
And if I give them the topical estrogen, it goes away.
Okay, so does it go away on its own, or do you have to have topical estrogen for it to?
It does not go away on its own, ladies. It is a chronic and progressive part of our rite of passage called menopause. It's good to start treating it when you have symptoms because sometimes it can be a bit too far gone and then it's hard to treat. Yeah.
Okay. Well, so we're talking a little bit about this topical estrogen.
Yeah.
So that resolves. Do you have to keep using it, or is it just when you have those symptoms? How does it work?
It's meant to be used regularly. So the idea is that because we know that GSM is progressive, so therefore you need to keep treating it for a long time.
Yeah.
as
So if
well.
you don't treat it, it's going to get worse, or even just through perimenopause, it'll get worse.
and beyond menopause. So what we usually suggest is that women start taking the therapy, which Dr. Mother will describe in a sec what it is. But once you start it and it's the topical or local therapy just on the down under parts, then within about 4 weeks,
Yeah.
most women will notice a fairly good effect of having the topical estrogen, and then you just titrate it. So if you're having a lot of symptoms, you can go up on the dose as you finally get through menopause and out the other end. If your symptoms aren't so bothersome,
Dial
just
it down.
dial it down.
Yeah.
So you know how we've all grown up saying moisturize your face in the morning, use your sunscreen. So maybe it's something similar, right?
Moisturizing.
It's so moist. If you're going to moisturize your face because it's a little bit dry and you want to protect it, do it to your underparts as well.
Oh, yes.
Why-
with the
Yeah,
right-
don't
with the-
neglect.
Yeah, so
not
let's
with
no,
dryness,
let's
but
talk about the
with
treatment
estrogen,
options. So
yeah.
I largely prescribe estrogen creams, but there's also ovules, like tablets that you can put into your down under parts. We're gonna call it down
No,
into
you're
your
the
vagina,
doctor.
into your vagina. There's silicone rings, there's inserts, and there's like ovules. So there's different things that you can use. So you can use this along with the oral or the oral and the transdermal estrogen. This is just as local. This we're just talking what's going to affect the down under in your vaginal bladder area, and they have fewer side effects or risks than if you use MHT, menopause hormone therapy, orally or systemically.
Which means you can use them. So they're not the same as the MHT where you have to start them, within 10 years of menopause. These you can start later. So
Yeah.
if the symptoms aren't bothering you until you're in your 60s, 70s,
Yeah.
80s, you can start them.
And I do have women who that's absolutely true.
Okay.
Yeah.
That's one way to address that issue. So the other thing that I'm thinking about is like you talked about dryness in your vagina. So if you don't have enough natural lubrication anymore because of less estrogen,
Yeah.
what can you do then?
Yeah. So you can use lubricants and moisturizers as well, but don't consider them first line. So if you know that the reason that you're having the vaginal dryness and irritation is because of genitourinary syndrome, then your first line treatment should be topical estrogen. Use the lubricants and moisturizers in addition, but it shouldn't be first line treatment. I actually, one of the things I came across was that you should think of vaginal estrogen as the Viagra,
Oh.
right? So it improves your blood flow and the sensitivity and the function, everything in the area of the vulva, the perineum. So it makes it more like it was before you hit that stage in your transition.
So you possibly could go from finding having sex painful to actually really enjoying it.
Absolutely. Yeah, that's a big part of it for sure.
Okay.
So there's hope.
There is hope, thankfully. I'm going to do a little bit of myth busting. We've done some episodes purely on myth busting, but I think there's some stuff around our menopause, sexual health about that we need to talk about.
Yeah.
So can you use the local estrogen if you're already on the systemic hormone therapy, which is the one where you're the oral?
Yeah. They go hand in hand.
up.
No, they don't double up. Local therapy can absolutely be added.
Okay.
Yeah, and we discussed that as to why. So yes.
Okay. And I touched on that I can't take estrogen therapy because I'm on breast cancer. Is that also like an individual case basis?
So I think there's a difference between like if you've got a family history of breast cancer versus your own risk
Personal
of breast
history, yeah.
cancer.
Okay.
So if there's a family history of breast cancer and you're worried, like, will this give me cancer? No, there's been no links to using topical or local estrogen therapy with developing breast cancer. So it's completely safe to use if there's only a family history. But if there's a personal history,
Yeah, then again, no, actually, what I've been reading lately, and again, talk to your doctor about this, is even with a personal history, because I do have a patient who has a breast cancer. She's still using it locally, and it is okay by the oncologist for her specific type of cancer, breast cancer. Yes, so she is using it. So, and again, you do have to talk about it. You can't just take it for blanket statements. You have to talk about it.
Yeah, and it's
for sure.
individualized, just like any kind of
Absolutely.
treatment is, right?
Yeah.
Depends on your
So
own
it's
body,
usually
your
a
own
low dose.
experiences.
She really needs it, and she does well on it. And again, she's talked to the oncologist. I've talked to the oncologist. We're all fine. And she does regular screening.
Perfect. Very important. One of the things we were just kind of touching on was sexual health during perimenopause. You know, if vaginal dryness, irritability, all those things can be a turnoff. So how common is this in women going through perimenopause?
yeah, it's very common. I mean, about 40 to 45% of menopausal women will report some sexual concern. And that includes things like low interest in sex in about 40%, trouble with lubrication in about 40%, pain with intercourse at about 20%, and then another 20% just saying, you know what, I just don't find it pleasurable anymore. So there's a lot of sexuality concerns around the time of menopause.
So when men feel that the woman doesn't want sex, that he's being rejected,
Yeah.
it's not about him.
And it might be like if there's emotional issues in the relationship, that is part of it. So that's not the blame all on
But
menopause.
there is physiological
There are
reasons that
physiological
women-
changes, yes. So you have to look at the whole thing. Sexuality is a multifaceted
And that's,
thing.
I think that's a whole other
That's
topic.
a whole other topic.
Yeah,
Let's
yeah,
not
we
get
Should
into that.
actually talk about
We'll
that
talk
another
about
topic.
that some other time.
Yeah, and then exactly.
I'm going to
Lots
talk
more
on
to say.
testosterone
Okay.
slightly because a lot of my patients will ask about it. Honestly, I have not prescribed it out because we'll usually do all this stuff first. We'll talk about the mental health, the relationship. We'll talk about local estrogen. We'll talk about MHT. But you can use testosterone. I've seen some OBGYNs prescribe it. In my own personal patient population, I haven't seen it that successful. But having said that, there are some women who it is indicated for, but they should go talk to a specialist about that.
And I think from what I learned at the conference
Yeah.
that I was at, that sort of the main evidence-based reason for women using it
Yeah.
would be if they have now developed unwanted low sexual desire. So if they want to be like more sexually active and more interested in
Yeah.
sex and they don't have it and they want it back,
Yeah, yeah.
and the estrogen and
It's not
progesterone therapies are
working,
helping, then they
Yes.
can talk to their
Perfect.
specialist about taking
Perfect.
testosterone supplements.
Okay. So hormone therapy seems to be like the way to go if you have a lot of these menopause symptoms, right? But what can we do ourselves in addition to the hormone therapy? How can we get ourselves in a place where maybe we're not feeling some of those symptoms? We've always talked about, eat healthier, strength training for your bone density, socializing. What else can we do in terms of helping our health?
So there are other aspects of our health that we need to take care of other than say our hot flashes, our vasomotor symptoms, and in addition to our pelvic health and genital urinary syndrome, and that includes muscle health, bone health, and metabolic health. So those are sort of three extra things that we can do ourselves without having to just rely solely on medication to help us through. So is that what you're referring to? We can talk a little bit about muscle health.
Yeah, that's what I was thinking about. Like, is there something we can do to make ourselves somehow stronger, or maybe not have some of those genital urinary issues?
Things we can talk about it from a pelvic floor physiotherapy aspect first, and then talk about the metabolic thing. So pelvic floor physiotherapy is not your mom's Kegel exercises. There's the way you sit, squeeze, while you're on the toilet, try to hold your pee. But you actually go to someone who specializes in the floor. So basically, your pelvis, the down under area is held up by a bunch of muscles. You need to strengthen those, and there are people who specifically know how to strengthen those.
Yeah.
Okay.
Yeah, there's physiotherapists that are trained in helping you regain your pelvic floor strength. And so like Dr. Mother was saying, that pelvic floor is what helps us with our core strength. It helps us hold everything up, our bladder, our ureters. And so when that starts to, become more lax over time, they can help you to improve your urge incontinence. They can help you with all the irritability of like running to the bathroom. And so, yeah, I think Dr. Mother, you've got a few tips for us about that too, don't you?
Yes, I do. It's just in bladder habits. Like often we'll just go, oh, I could just hold it now. It's okay. I'll go later. So try to go.
I did that this morning when I was at the doctor's office.
And so try to go to the bathroom one time. When you void, you think you're finished, just sit again, see if you can void again. So it's not leaking or dribbling later, like a double void.
Okay, one tip I learned was if you think you're done but you aren't sure, lean forward.
Yes.
Right?
Yes, that's true. That's a good tip, actually.
Yeah.
And for bowel health, so important. Please don't get constipated. Eat your fruits, your vegetables, drink your water, because when you strain to poop, it's affecting your pelvic floor muscles.
That is true.
Yeah.
I will see people in the emergency department who've come in with urinary retention, meaning that their bladder is so full they can't pee.
Yes.
And the reason, they are super bunged up.
Yeah. They're full of poop, and the poop is not letting them pee.
Yeah. And that is making them not pee. Isn't that crazy?
Yeah.
And how do those sorts of things affect your life in general?
In what way do you mean?
Well, I mean, like, so why should we care about strengthening our pelvic floor?
Because otherwise you'll be leaking all over the
Yeah.
place.
But could you also imagine, like, if you've been invited to like a baby shower and you're like, oh, I don't know if I can go because I don't know if I can hold it in.
Yeah, it does.
Basically, I don't want to be wearing Depends, so I will try to keep my pelvic floor muscles as strong as I can for as long as I can.
Did you know, interestingly, 1 out of 3 women over the age of 40 has urinary incontinence? Like that's
Yeah, but I believe that because I was playing pickleball and I could have gone for the shot, but it would have required me to lunge, and I didn't pee before playing pickleball. And I go, I'm letting that ball go, so I lost my
Yeah,
point.
yeah. The bottom line is that, ladies, pelvic floor issues during the menopause time are common, but they are treatable. So you don't have to suffer in silence.
Perfect.
Perfect. That's
That's
good to know, right? Nobody wants to suffer.
No.
Um, where I do suffer is sometimes when I'm in asleep and I'm getting the hot flash and I wake up and I'm disturbed and trouble getting back to sleep
I
again.
agree. I don't even get the hot flash, but my sleep is disturbed.
Yeah.
Yeah, that is
Even
true.
without it. Yeah. And that's very common as well. Like about, again, another 40 to 60% of women that are going through menopause will have sleep disturbances independent of vasomotor symptoms. So it is not just affecting your nights, because then your poor sleep that night affects
Affect
your
your
mood,
days.
it
Yeah.
affects your productivity, it affects
Yeah.
your overall quality of life.
And sometimes for me, when I know that I'm gonna not be able to have a full night of sleep, I don't want to go to bed, and I'll try to delay it as long as possible because I dread being awake at night.
Yeah, yeah. And you know what? I'm going to admit to this because
Yeah.
my mother already knows this.
What is what?
But another thing that happens around menopause is that you can get obstructive sleep apnea, which means you can start snoring.
Oh, I was about to say, Avery.
I've shared a hotel room with this lady, and she has actually audio taped me and then played it back to me the
Because
next
I was
morning.
awake and so I was bored, and I go, if I tell her, she's gonna snore, she's not gonna believe me, so I just put my phone on.
So yeah, even though we're not typical like who you'd expect to be snoring, like men with thick necks or large body habitus, yeah, even women that have never had problems with snoring before
Yeah.
may start snoring during perimenopause.
Yeah.
Yay! So we've touched on a lot of things. Can you summarize for me, like muscle health, bone health, metabolic health, the 3 things that you were mentioning earlier?
Yeah, these are things that you can help yourself with outside of hormone therapy or other menopause specific therapy. So the first thing, I think you want to talk about muscle.
Maybe your muscles, like we've talked about before, you're losing muscle mass. How do you build it? Eat properly, get enough protein in, exercise, weight resistance.
Yeah.
So even if you're doing squats on your own, you don't have to take weights, or you could take very light weights. Just do something.
And build up your strength, right? Like if
Let's
you
just start with doing it. Let's not get excited. Okay? Let's just start build.
Yeah, I'm building.
Yeah, let's just build.
so you start building muscle health, and when do you start losing some of this muscle tone? At what age?
You start losing your bone health at 30. You start losing your muscle health by the time you've hit menopause. If you're losing your muscles if you're not working out.
Yeah,
And it's a huge drop off once menopause hits.
yeah. So it
End of
doesn't
story.
start during menopause, is what she's saying.
Yeah.
It starts earlier,
It starts
but it does
earlier.
drop off even.
Enjoy your 20s, girls.
And how do we optimize our bone health?
Yeah, that's the important thing here. We've talked about osteoporosis in the past, and that 1 in 3 women are going to end up having an osteoporotic fracture in their lifetime, which is huge, right?
Like just
So
falling.
yeah, it's
Like
a regular
when you get
fall,
hip
even bending over.
fractures and stuff, yeah.
even
Or
bending over.
a lumbar fracture, yeah.
Mhm. So we, again, same thing as for muscle health. You want to do resistance training. You want to do impact, like jumping type of exercises if you can. Even if you can barely do a jumping jack, just do light impact exercises. I know you had mentioned to me earlier about weighted vests and should we use them? They might be good for cardio, but they're not going to do anything for your bone
Oh, good
health.
to know.
Yeah,
Good
so
to know. I
don't.
didn't know that.
Yeah, there's no point in
Okay.
walking around the neighborhood in a weighted vest because you think you're strengthening your bones. Wear them while you're doing your squats and lunges to add a little bit more resistance, and that's how they help.
And take your calcium and
Oh,
vitamin
yes,
D.
of course, yes.
Very important.
Okay. Metabolic health is our inside functioning,
It's our
right?
South Asian, we're have
Our
stamp
genes.
on. It's our genes.
Can we improve that?
Yeah, well, yeah, of course you can. It's again diet and exercise. Diet, exercise, get your protein in. But by metabolic health, we're talking about diabetes, high blood pressure, cholesterol, fatty liver, all that stuff. I know we've said it again. I'm sure you're bored. We are too. Diet and exercise.
Okay.
That's it.
Long episode. Thank you
Lots
for
of stuff.
tuning in. Any final words, takeaways, a message you want to leave our listeners with?
Don't be embarrassed to talk about it. It's a rite of passage. Own it and make sure that you are optimizing how you feel so that you can live your best life, because life is to live.
Yeah, and just if you have symptoms, there is treatment for any symptoms that you might have during the menopause time. There are specialists that can help you. There are family physicians that can help you. Talk to your friends, talk to your family members. But if you need help with your treatment for your symptoms, there is help available to you.
Yeah, you're not alone. We're all going through it.
We're all
together.
going
We're
through
all
it.
going through it.
I, for one, am so glad we're having this conversation, and I'm going to graduate from calling it the down under parts to the bladder and the vagina. We appreciate you listening in. Really important topic, so relevant to women in our age group, also our families, our children, our partners.
Yeah.
So let's understand a little bit more about how our bodies work, what we can do to make them work more effectively, efficiently, and make sure we share this information. So please share this podcast episode with those you love. You can like our podcast, share it, DM us with questions, suggestions for new topics, and follow us on all your social medias. We are Avaz Health. Thanks for tuning in. The information in this podcast is not a substitute for professional medical advice, diagnosis, or treatment.